Hey everyone, my name's Bonnie, and today we're going to talk a little bit about prone therapy in the acute respiratory distress syndrome, or ARDS, patient population. So before we get started, the way I'm going to kind of navigate this presentation today is between the PowerPoint that you see below, as well as on the whiteboard function, where I can just kind of draw and maybe elaborate on some concepts that I think might be helpful for you guys. So I'm going to head back to that PowerPoint right now. And before I go any further, I am also going to sort of hide this video panel thumbnail off to your right. All right, so objectives for today, we're going to talk a little bit about the rationale behind prone therapy and prone positioning as it relates to improving oxygenation and reducing lung injury in a particular patient population, and that is patients with ARDS. Before we really get into what happens when we prone people with ARDS, we're going to look a little bit at ARDS just on a very, very basic level. For more information on ARDS, you're welcome to visit a video that will be uploaded shortly that focuses really predominantly on the disease process itself and not the treatment of prone therapy. So something that I think is kind of interesting is sort of how therapies develop and how they change over time. And with ARDS or ARDS, in the late 70s, this disease process had around a 70% mortality rate. So that's incredibly high. And, it really wasn't until the mid 70s where we started really looking at, how does sedation and how do paralytics affect different disease processes? How does it affect the way that people breathe and our ventilation? How does turning and recruiting maneuvers affect these things? And with prone therapy, this historically has been, the research has been sort of led by anesthesiologists and pulmonary critical care. Nursing has really kind of owned this, and prone therapy being kind of a nurse-driven practice historically. Now, in my current clinical practice, I don't see this as a nurse-driven practice. I, for the most part, see it being physician-led and nursing carrying it out. And I think some of that is just sort of cultural changes as technology develops, and so does our practice in medicine. But, we'll talk a little bit about this later, about the effectiveness of prone therapy. And I think that will kind of indicate as to why I'm such a fan of using prone positioning to treat ARDS. So what is ARDS? ARDS was first described in the 1960s. During Vietnam, we started seeing, lots of this heterogeneous underlying disease in the pulmonary system. And something that's really interesting to me is the occurrence of ARDS in the United States. If you look at some of these numbers that are below, 33.8 per 100,000 in the US, and look at that compared to the numbers in Europe. So this is really remarkable. This is, somewhere around 7 per 100,000 in Europe. So, why do we have such a higher prevalence of this in the US? I could take a couple guesses. I haven't done really a lot of research to speak about it in any sort of educated fashion, but I do think that is sort of an interesting, distinguished statistics that kind of stands out to me. The other thing that I want to spend a little bit of time talking about is this idea of a heterogeneous underlying pathological process. So what does that mean when I use the term heterogeneous underlying pathological process? And what that means is that as the respiratory disease develops and injury is occurring in the lungs. So we're going to go down to this very last bullet where we look at edema is increasing the lung weight. That edema is really pushing and squeezing gases out of the dependent regions in the lung. And what that leads to is alveolar collapse. Now, when we have alveolar collapse, we're going to end up with an increase in densities in these dependent regions of the lungs. So what that in theory looks like is that instead of really nice homogeneous lungs, which is really what we're going for, we end up with this heterogeneous process. So just to remind you guys, homogeneous meaning that it looks relatively the same throughout the lungs, and heterogeneous meaning that there are areas that are very, very different. And we'll talk a little bit more about why that can cause us a lot of trouble when we talk about ventilation and oxygenation and the development of ARDS. So what we have here, we have a couple of really key concepts. And the first one of those is, air is going to go to the pathway of least resistance. When we add volume, if someone is mechanically ventilated, that air is really going to travel into the part where it meets the least amount of resistance. And so why is that important? So that kind of tells us a little bit about why prone therapy might be helpful. So let's just switch over real quick to this whiteboard. Okay, so I'm going to take a patient here, and I am going to, and you guys forgive me on my long drawings here. So this is a patient who is completely upright. Okay, so this person is in the upright position. Okay, and now I'm going to take that same person, and they're going to be laying supine. Okay, and I know it kind of looks like there's only one lung, but so in the upright position, what we said was that as edema increases the lung weight, it squeezes gases out of the dependent regions. So that's going to be these regions down here in kind of the bases of the lungs. And we tend to have alveolar collapse and an increase in densities. So this is where we really start to see kind of an increase in these densities in the lower lobes. And when we lay that on our side in the supine position, we are going to end up essentially seeing those opacities in the dependent regions at this point, which really correlates to the posterior aspects of the lungs and kind of all throughout. But what I'm looking at is if this area of the lung and this area of the lung look very different. So what does that mean? That means that this is heterogeneous versus if the lungs looked like this and the opacities here were spread evenly throughout the lungs, this would of course be an example of a homogeneous lung. So when we have the patient laying down supine, this is going to be our bronchial tube, and most likely, in this scenario, I want you to picture somebody who's intubated, who, is laying down, is supine, and yes, we're turning them left to right, but, those 30-degree, maybe if really aggressive turn, 45 degrees, typically not enough to really shift and break up those pulmonary, that atelectasis that's setting in there. So when the air enters into the lungs, really, I envision this somewhat like me driving in driving on the highway or the interstate. And one path, as I let me just switch colors here. I'm gonna go to blue. So as I drive down and I look to my right and I see, oh gosh, I see a massive traffic jam. Okay, so I'm not going to choose to go to that direction. Instead, I'm going to choose to go to the left, which is a completely open area. So what ends up happening in this scenario when we have a heterogeneous lung disease is that the area that really needs strong ventilation, which is going to be this part down here. This is the area we want to ventilate. However, this is the area that we actually ventilate. So you can kind of see that difference in how that might be dangerous. especially if what I'm assuming about this patient who I'm mechanically ventilating, and what I'm assuming is that based off of some ventilation calculations, that this person should be able to take 500 cc's of volume, and for their tidal volume. And what has essentially happened is perhaps maybe a third or a half or something like that of this lung space has been really taken up by the disease process that's occurring. And so we have to adjust, and we sort of lose some of that. Now we want to apply positive pressure to the ventilator in order to break some of this up. Unfortunately, when we apply a positive pressure, the air only continues to go to the areas of least resistance. So the big takeaway here is that air will go to the area of least resistance, just like you and I would probably do if we were, driving our car and had the option to avoid some traffic if we could. So we end up putting extra pressure on the healthy lung tissue up here, and not enough pressure on the injured, or not injured, on the edematous lung tissue down here. And what that results is oftentimes injury to the healthy tissue. And depending on what's going on, that may be what we refer to as barotrauma. Okay, so let's take just a quick look back at the PowerPoint. We're going to swap back over and make sure that we've hit all of these points. Okay, when we add more volume, we can certainly cause injury of areas in the good lung. Of course, that makes sense if we think about that drawing. And the end result really is that we overextend the areas of good lung, and we cause injury to the to those areas, and we really don't recruit the areas of edematous lung. And our goal is to really create a more homogeneous state. If I have a homogeneous state, and I'm going to take that same patient lying supine, if I have a homogeneous state that looks like this, when air enters, it will circulate kind of evenly, and it's much easier for us to regulate how much pressure and volume is going in, and we can much more safely mechanically ventilate somebody who looks like this with a homogeneous pathology. All right, so this is just a little bit about ARDS diagnostic criteria, and it kind of breaks down the mild, moderate to severe, needs to have a chest x-ray, and really what we're looking for that differentiates ARDS from other types of respiratory failure that may be kind of fluid related is that ARDS is a respiratory failure that is not explained by CV failure. It's not explained by cardiac dysfunction. And it's also not explained just by complete volume overload. So sometimes I do see patients who simply are in respiratory failure because they were given 11 liters of fluid when they presented to the emergency department. Of course, when we get the fluid off, things are going to look a little bit different. And when evaluating somebody for ARDS, one of the first questions I'm going to ask is, do they have CV failure? And if the answer is no, then I really start to look into, do they qualify for ARDS diagnostic criteria? And if so, let's move kind of down that treatment. Oftentimes, I'm looking for a P to F ratio somewhat of less than 150 before I start to really look into more advanced ARDS treatment. They need to have an FiO2 of at least greater than 60, and they definitely need to have a PEEP greater than 5. Okay, so treatment for ARDS. Treatment for ARDS really hasn't changed very much in the last many years. We probably the biggest contribution to ARDS treatment has been the low tidal volume ventilation. So that came out in the 80s. It is a very, very common practice now. And what that means is basically when we have somebody who is on the ventilator, who is in an assist control, volume control, is normally when we are calculating a tidal volume for a patient who's going to be in a volume control setting. Normally, we may calculate anywhere kind of this 8 cc's per kilo of ideal body weight is a kind of a standard way to calculate what their tidal volume is going to be. When we look at someone with ARDS or someone with, lung injury, we're looking at low tidal volume ventilation. So instead of 8 cc's per kilo, these patients are going to be much more safely ventilated on something like 6 cc's per kilo. And in some situations, I've seen all the way down to 4 cc's per kilo. And one thing that you'll notice is that on this is per ideal body weight. So that's really, really important to remember because, if I have person A here who is, 50 kilos, and this is their lungs, this is their chest, here's a head. So I have a person here who's 50 kilos, and now all of a sudden that same person gains another 50 kilos. Okay, so they've just doubled their body weight. Now they're 100 kilos. So what we have here making up this space, a lot more adipose tissue, a lot of extra stuff going on. But something that hasn't changed is the size of their lungs. Okay, so it is really important to use ideal body weight when we make this calculation. And this is something that respiratory therapy and the respiratory therapists that I work with, of course, have lots of training on, and pretty much the way that we calculate tidal volumes at a baseline. So very, very important. Probably the most important thing that we can do to not cause injury to these patients is to practice very low tidal volume ventilation strategies. Another type of ventilation that we really don't use in the adult population anymore is high frequency oscillating ventilation. I haven't seen this used in an adult in quite some time. So I'm not going to spend any time talking about that. Of course, everybody has questions about ECMO, extracorporeal membrane oxygenation. The thing about ECMO, I love ECMO. I think it's fascinating. I've really enjoyed working with ECMO patients when I've had the opportunity to do so. The survival rate for ARDS and patients on ECMO is just not that good. The evidence really, for the most part, doesn't support putting, just numbers and numbers of ARDS patients on ECMO. It is usually in these scenarios more appropriate to use as a bridge to lung transplant, or I've seen much more success in patients that have severe cardiac dysfunction. And of course, I have seen patients in ARDS get better on ECMO. However, the evidence that we do have in adults with really severe advanced ARDS doesn't support it certainly as a frontline therapy as patients progress into severe ARDS. What we do have evidence to support as a frontline therapy, and this is I, of course, like prone therapy. It's a lot less invasive. It is to flip these people, to put them prone in the bed, because our overall goal is for these individuals with ARDS to get better, is to improve. And how do we get them there is we have to recruit their alveoli. But I also want to be mindful of, I don't want to just recruit your alveoli and really, give you severe lung disease for the rest of your life. I want to recruit your alveoli, and I want to do it without injuring your lungs. And that's the most important thing. Can we recruit the alveoli without injuring the rest of your lungs? So just a quick note about ARDS treatment. Of course, I've got some other talks on things like this with analogous sedation, sort of what should your RAS goals be. A lot of people have questions about paralytics when you're managing a patient who has ARDS, and how to really kind of manage the neuromuscular blockade and ventilator dysynchrony. So if you want more information on those, we'll have some talks coming up that sort of cover a little bit more on that. I just wanted to include them as sort of other considerations to be thinking about. Okay, so I want to take a quick look at when we look at sedation and we look at paralytics for these individuals. And this study that was done that supports the information on this slide was, not done in patients with ARDS, just as a disclaimer out there. But it does give a pretty good depiction of what happens to ventilation, which is, of course, kind of the movement of air coming in and out of the lungs. What happens to ventilation? What happens to the diaphragm when somebody is awake, when somebody is sedated, and when somebody is paralyzed? So first, we're going to look at awake and spontaneous. This is going to represent our normal breathing pattern. So this should be how we are all breathing normally right here. And what happens here is you can see that the diaphragm essentially, so this is our diaphragm right here, essentially acts as a shield for any pressure coming out of the abdominal area. So it does a really good job kind of keeping all of the abdominal contents away and allowing the lungs enough space in this cavity to do what they need to do. All right, so what happens when we sedate and anesthetize this person? When we sedate and anesthetize, the diaphragm, which, is a muscle, it also kind of gets a little sedated, a little sleepy. And so it actually loses some of its function, and it loses a little bit of that shielding function. So you'll notice that the space here is much larger than the space here. So the diaphragm really starts to not be able to shield the lungs, not to give the lungs as much space as they would have otherwise when we start to anesthetize people. Okay? Next, let's look at paralyzed. All right? Like I said, the diaphragm is a muscle. So when it's paralyzed, it almost completely loses its shielding function. And what that does is really the diaphragm, and you can see this in the depiction, the diaphragm really sort of slumps back and starts taking up some of the space that the lungs had otherwise. And the other thing that you'll notice here is the way that air flows into these models, these drawings, is that the majority of the air when someone is sedated now, paralyzed, is now getting shifted up into the anterior part of the lungs, which, in this particular picture it is in a superior plane. So really that upper portion. And so that's when we really start to get these, remember those dependent opacities that I was talking about, where gunk really starts to build up down here because the diaphragm has just made it even harder for this bottom part of the lungs to expand and really, really do its job. And part of that responsibility is also, you can see these changes in pleural pressures, awake and spontaneous, sedated, relatively similar. That's kind of makes sense if we think about how air is entering into the lungs. And then when we paralyze somebody, we get some pretty significant changes in the pleural pressures, which just makes it even more difficult for the bottom portion of those lungs to expand. Okay, so why prone? So bear with me while I talk about statistics for just a second, because this is really just really mind-blowing to me. So you can see some of the survival rates at 28 days and 90 days. And of course, those show that, proning individuals does increase survival. End result there. The thing that blows my mind is that the NNT for proning. So NNT stands for a number needed to treat. So NNT, number needed to treat in order to save a life. So the number needed to treat to save a life in prone therapy is 6. So that means that for every 6 individuals with ARDS that we prone, one of those individuals, we will save their life. And when I first heard that statistic, I had, thought, well, that explains why, 5 out of the 6 patients are going to die. And I thought, well, that's not that good. I mean, 5 out of 6 are dying. Yeah, we saved one person, but what about the other 5? And then as I looked a little bit more into kind of what does this NNT really mean, the standards of treatment for things like, a baby aspirin for some of our cardiac patients, standards of therapy for medications that have been widely accepted and widely practiced for years that evidence continues to support over and over and over again, often have NNTs somewhere in the 20s. And we consider that to be really, really strong evidence that this is the best practice, an NNT in the 20s. So an NNT of 6 is actually incredibly statistically relevant and a really should kind of indicate to you that this therapy has the potential to save a lot of people. If we go back to that prevalence of ARDS in the United States, almost 34 per 100,000, well, we have the opportunity to really make a difference in some of these people's lives. So other than, once we look at the statistics, what does proning actually do for us? Why does it increase survival? Why does it help us save lives? Is it really does some primary things. And the first thing that it does is it improves oxygenation. When a patient is proned, their oxygen gets better. Their respiratory mechanics get better. And because their mechanics get better, their oxygenation gets better, all of that is a result of this alveolar recruitment down here. We start to recruit the alveoli, so we get better oxygenation, we get better respiratory mechanics, and we get a reduction in ventilator-associated lung injury. So not only are we doing a better job with their gas exchange, but we're injuring them, and we are putting less stress on the lungs, which will allow them to actually do their job and eventually heal. And so that's really, really what we're looking at. The other thing that happens when we prone people is that, and this is part of that alveolar recruitment, is when we turn somebody from a supine to a proned position, is a lot of those posterior basal densities really start to redistribute, and they go into the newly dependent area of the lungs and create a more homogeneous picture. So let's look at what does that look like. Let me just draw a picture here. Okay, so if this is my patient, they are laying supine, and this is their airway. This looks like a potato, but it's supposed to be a lung. And this person has been laying supine, and they have really developed just a lot of posterior basal opacities and just infected gunk and stuff down there. And then we rotate that person. And in the prone position, when we immediately rotate them, now what we're going to see is all of those opacities, all of those densities, all those drainage and edema is now on top. Okay, so what do we know about gravity? In this situation, gravity is our best friend. The drainage has collected here in the supine position because that is what gravity has told it to do. In the prone position, the the fluid that has collected at the top now is fighting against gravity, and gravity pretty much always wins. So now that drainage starts to sort of infiltrate other areas of the lungs, which you might think, well, that doesn't sound good, but as it starts to kind of move into other parts of the lung, what happens to the density of it in this particular region is that it gets significantly less. And what's our overall goal for these patients is, that's right, we want the lungs to look homogeneous. We want them to look the same all the way across. So as these secretions drain, I'm going to see end result. What I want is that there is a very homogeneous looking lung, and it may still be filled with edema and just, gunk, infection and gunk. But when it's homogeneous, the air that's being blown in can really distribute in a very even pattern. And what does that do for us? It reduces our chance of lung injury. Whoops, can't spell. And also allows us to recruit the alveoli throughout the entire lung field and not just one section like we have earlier. Now, if I'm a nurse taking care of these patients, a lot of times what I'm going to see in this scenario is I am going to start to see some effects. It's really clear when this happens, when we first prone people and these secretions, this edema, this fluid really starts to break up and sort of drain into the newly dependent. So this would be the newly dependent, the area that is now on the bottom, because what happens to that patient is, as these secretions loosen up, they start really pouring out of the patient's facial orifices. So lots of drainage coming from the nose, lots of drainage coming from the mouth, and it's almost, it's really difficult, can be really difficult to kind of keep up with it so they look presentable. But one of the things also our visitors to really reassure them that this is exactly what we want. We want it to be, because when it's draining out, that tells us, this is starting to break up. And of course, I don't go into the details of it's breaking up and we're, working our way towards a more homogeneous pulmonary pathology. I think that would be probably a little much, but to be able to explain to them that this is actually a very, very good sign. It may look a little gross, but it is actually a very good sign. Okay. So the way that the institution that I'm at, the way that we do prone therapy is we prone the patients for ideally about 16 hours. And then when that 16 hours is up, we will supine the patient. And we'll supine them for at least 4 hours, depending on the patient's condition. So I wanted to look real quickly at what are the benefits of prone versus supine. So when we have someone in the supine position, okay, of course, here's our supine patient, and here is their dependent lung opacities. So what does this mean? I'm going to get a reduction in the lung volume because the only space that I can actually ventilate is this space right here. All of this is kind of off limits because it is so dense, full of edematous materials and kind of opacities. So what does that lead to? If I only have half of the, the top portion, the non-dependent portion of the lungs to really ventilate, I get that drop in volumes. I get kind of an alteration in the lung mechanics themselves. Not having as much space is going to lead me to a very, very high resistance sort of ventilation, and also something with very, very low compliance. These lungs are not going to be very malleable. And we're also going to end up seeing a lot of, atelectasis from compression and weight sitting on all of these opacities. And of course, the end result to all of that is we are losing a fair amount of the lung tissue that we use to have gas exchange. The end result of being in the supine position with ARDS, as these physiological things start to occur, is that these patients end up looking very hypoxic. Okay, so that's sort of, the downside of the supine position. Now let's look at what happens when we prone patients. Now I'm going to flip this picture upside down again. This person is prone. So I have an increase in what's called functional residual capacity. We'll look a little bit more at sort of what that means, but basically it means there's more space for me to ventilate. I'm going to get an increase in compliance with that additional space as this stuff starts to really fall and I get more of a homogeneous structure. There's gonna be shifting of the lung waters, the densities. I get that homogeneous structure, and the end result of all of those things, an increase in residual capacity and an improvement in compliance, shifting of densities, all of that, at the end of the day, results in an increase in oxygenation for these patients. So we've talked a little bit about this. I'm not going to go into it again, but gravity and the weight of the lung is your friend when you prone. This is what happens when we change position and we use the patient's weight. And those things are really going to influence our pleural pressures to allow the lungs to expand so that we can help ventilate these patients more safely and more effectively. So I think this is hopefully, not too repetitive, but my background is in prior to getting into pulmonary critical care, and my background was very CV heavy. So I always have to throw in a little something about, the cardiac system. But I do think it's really important to pay attention to this, because something that happens when we shift people so significantly from supine to prone to back to supine is that we see some pretty significant hemodynamic shifts. And so I want to talk a little bit about why, because some of these hemodynamic shifts are very predictable and can be significant, but are not necessarily a cause for panic. Whereas other hemodynamic shifts that occur are positive and helpful, and that's what I'm looking for if I think prone therapy is going to be effective. So let's look at what's happening hemodynamically when I have a patient in the supine position. So this is, an individual lying straight on their back. So this is their spine down here. And then I've got the lungs right here. Okay, so the cardiac structures, the sternum is up here. When I'm lying flat on my back, I've got the cardiac structures all sort of sitting on, putting pressure on the lungs, pressure on the spine. And what does that mean from a pulmonary standpoint, from a lung standpoint? So almost 20% of the lungs sit up underneath the cardiac structures. Okay, now if that patient has a large heart, they have cardiomegaly, it can be up to 36% of the lung structures being on top of or being below the cardiac structures. So what does that mean? It means that there is constantly a positive pressure kind of sitting and putting pressure on the lungs. So that gives us a more positive pleural pressure, the space around the lungs. And what does that do for the lungs' ability to expand? It makes it more difficult for them to expand. More difficulty expanding simply leads to collapsing of the alveoli. And what is our primary goal when we want to treat ARDS is, of course, recruitment of the alveoli. So if this is our main goal, to recruit the alveoli, then why would I want to be putting pressure and making that more difficult than it already is, and perhaps somewhere around a third of the lung structures? Well, I wouldn't. And so that is why, that's another reason why prone positioning can be really beneficial in these patients. So the last question down here, it says, what should we expect when we supine somebody from a prone position? So I want to answer that question a little bit later, and actually not right here on this slide, but it's a very, very important concept that we talk about, and it's definitely been the cause of lots of staff that I work with to have a lot of discomfort and panic when we supine individuals. So we'll definitely talk about that a little bit later. Okay, so when we prone somebody, all right, so this was our cardiac structures. Now I've got those on the bottom. Oh, got those on the bottom. I've got this a little bit backwards, sorry. Not cardiac structures on top, but this would be the spine on the top. So when we prone somebody, I've got spine on the top, sternum on the bottom, and now because of where the spine sits in the middle being much more narrow, the pressure that was on the lungs in the supine position has now been completely offloaded. Okay, so in this scenario, when somebody is in the prone position, that 17 to 35-ish% of perhaps of lung tissue that, or lung space that could be potentially influenced by the cardiac structures is now taken all the way down to 4%. So what that allows, less pressure on the lungs, a lower pleural pressure around the lungs. I'm going to be able to really open up these alveoli, really improve the ventilation portion. And a lot of people look at changes in blood pressure and changes in heart rate, and they say, oh, we're just, are they perfusing? Okay. So something that I want you to think about just a little bit different is when we prone people, prone therapy works not because we're, really changing perfusion, which is the blood flow, right? It really works because we're altering the space available for ventilation and allowing for redistribution of that ventilation. And so I include that piece because I hear a lot of people talking about prone therapy as if it is a perfusion problem and perfusion that we're treating. But every example that we've talked about so far is, let's say opacity's down here, moves to opacities up here. If we talk about ventilation, remember, ventilation is the movement of air in and out of the lungs, okay? So the air movement in and out of the lungs changes as we change the underlying pathology of the pulmonary, of the lung space itself. Okay, so quick review on a couple of things. When we prone, our goal is a more homogeneous lung state. I hope if you take one thing away from this lecture, you take away that a homogeneous lung state is easier to ventilate. When we get a homogeneous lung state, we're going to get, and we prone, we are going to get a redistribution of our pulmonary pressures, right? So when we prone, we're going to get more negative pleural pressures, which will, as we redistribute some of that, we're going to really unload the stress and the strain that's happening throughout the lungs. That stress and strain backs up to the right ventricle. As we unload the workload of the right ventricle, unload the stress of the lungs, we're really going to end up seeing an improvement in cardiac output. So it is not uncommon for us to take patients who look pretty sick when they're supined and prone them, and almost immediately, within a couple of minutes, their oxygenation looks better, their blood pressure looks better, their heart rate looks better. It's a really incredible thing to witness, actually. So like I said, we're changing the space for ventilation, but something that is important is that the turning, the actual manipulation of the patient. So, this person is really, especially if they've been intubated in an ICU and they don't have a whole lot of oxygen reserve. Sometimes, I think probably most people have heard of sort of the how did bed 11 code? Well, he got the during the bath, the bath being the big thing. And so why do people code during baths so often in the ICUs? And I don't see this as much as I did anymore, but And this used to be kind of a regular thing where we'd go to bathe the patients and all of a sudden they would go into PEA or any systolic arrest. So a lot of that is there's an increase in oxygen demand when we turn, when we manipulate. And so it becomes very, very important for us to really space these activities out. It becomes really important for us to allow the patient to get back into an equilibrium. And so this is oftentimes why when we prone people, and we have them proned, and it's been 16 hours, it is time for us to supine. When we supine individuals, we we really need to give patients as much time as we can to really settle back out after a turn. And the faster that we turn, the more the equilibrium gets disrupted. So if we have an opportunity in the organization that I am in, we sort of do a half turn. We manually prone in this institution, so we do a half turn, and then we do the rest of the turn, which just kind of gives the patients a few seconds to really sort of recalibrate what's going on with them as far as blood flow goes. All right, so we've talked a lot about this. One thing I do want to mention is even if you are in an organization that does not prone, I wanted to talk a little bit about the theory of good lung down. Okay, so good lung down. Oftentimes when people get sort of acute respiratory diseases, they may have one lung that looks really, really bad and one lung that only looks a little bit bad with opacities. And so just like, we've talked about before, if we have, here's their trachea, if they are being ventilated and air goes in, the air is going to go to the pathway of least resistance. It's going to look at this side and think, oh, nope, that's a major traffic jam. So it's going to go to this side. So this lung will be very, very well ventilated, and this lung will be very poorly ventilated. And so the theory is good lung down. Basically, if this is my left lung here and my right lung, I would want to lie this patient with their left lung down as much as possible. Just to really promote drainage of that right side so that this person can have a more homogeneous structure across their lungs. And the good lung down theory, this is not new information. This has been around for, gosh, I don't know, 20, 30 something years. But it's just something that, I don't hear being talked about as much. And so I really wanted to point it out as even if you're in a place, an organization or a department that does not prone, you can still practice good lung down mechanics and really help create a better underlying pathological state. Okay, so this is just a quick explanation of what functional residual capacity is, and essentially it is the volume of air present at the end of passive expiration. And so I'm not going to go into very much detail with functional residual capacity, but I put it in here because I wanted you to see this slide right here. And this is what happens when we change people from position to position. So you'll notice that when we're in a supine position, these are the two that I really wanted to compare. When we're in a supine position, our functional residual capacity drops about 30%. Okay, so that is a loss of almost 800 cc's, 800 milliliters. We're losing 800 milliliters of capacity for our lungs. And that is very, very different than the prone, which is half that, 15%. So what this indicates is really, when we look at the most effective way to breathe, and this is really interesting, the most effective way to breathe is actually on your hands and knees, all fours, which is, also kind of supports this and gives us an idea why. All right, so we have talked a little bit about this already, where the prone positioning does grant us some really significant benefits. Of course, overall, it it allows us to not injure the patient's lungs. It gives us the end result of us not injuring the patient's lungs. That's really because it allows us to not hyperinflate kind of the non-dependent regions. We're going to get a more homogeneous lung structure. We're going to reduce our chances of barotrauma and atelectic trauma. And we're going to reduce our chances of further infection because we're going to get better drainage when we prone people. So this is always something that people ask me about is, well, how do I know who to prone? Okay, who falls into this category? There's lots of evidence for proning patients at different or various points during their ARDS when they fall into different diagnostic criteria for their ARDS. For the most part, the way that I see being practiced is that when a patient falls into severe ARDS and has a PaO2 or P to F ratio of less than 150, we're going to start looking at, can we prone these people? It is better to prone patients when they are earlier on in their ARDS course and those densities haven't gotten so incredibly dense. And of course, we talked about, using low tidal volume ventilation. These are patient populations that are considered to be, potentially eligible for someone who may need to be paralyzed, especially for having ventilator dysynchrony. And sometimes we will have patients who are receiving prone therapy and they are supined and essentially continue on the cyclical pattern of being proned and supined and proned and supined. And it kind of seems like we're almost stuck with them being proned. What the literature says, and this can be difficult to implement in the clinical setting, but what the literature tells us is that patients are not benefiting from proning if initially they have not had absolutely no response after 48 hours. They've had no change in their clinical status. That sort of indicates that they're not going to have a change, that this therapy is not effective for them. And then also, if their P to F ratio has remained greater than 150 for 4 hours after they've been supined, with a PEEP greater than 10 and FiO2 greater than 60, that tells us that this person may start to be falling out of that severe ARDS category, and we may be able to use other therapies on. All right, so this is more of a summary page. I'm not going to read these to you. This is sort of a summary of what happens when we supine, what happens when we prone, and what to expect when we prone. Of course, we've talked a lot about this: improvement in oxygenation, an increase in drainage. These patients do tend to have some facial swelling, especially depending on how you the process of how you actually prone them. Of course, we're going to get a more uniform distribution and an improvement in our hemodynamics. As far as these additional considerations, I want to take a minute to talk a little bit about what happens when we take a patient who's prone and we turn them supine. So it is not uncommon for patients who have been proned, who then become supined, to sort of acutely deteriorate after being supined or in the process of being supined. And so a lot of that has to do with kind of the reversal and the pressure that's happening on the lungs. But a lot of it as well can have to do with us not spacing out activities. It can have to do with changes in perfusion. And there's a lot of things that go into this. But essentially, giving that patient time to settle out is a very important part of supining a patient out of the prone position. And it's a very stressful part of the process. So the rule of thumb, what the literature tells us, is that if a patient decompensates immediately after you have supined them, it's essentially okay up to a certain point. So sometimes patients will not look so good and they will continue to not look so good. And when we start to reach that 15-20 minute mark, we really start to consider, okay, this is potentially somebody who needs to be reproned at this point. However, it's really oftentimes beneficial to wait that 15-20 minutes, because if they're going to continue to deteriorate and acutely deteriorate, the chances are that they might go into a cardiac arrest. And it is much more helpful to have them in the supine position if they arrest. Alternatively, if they have decompensated because of energy and oxygen reserve being depleted from the turn itself, if I turn around and immediately prone that person, I'm continuing to eat up more and more of their reserve. And now I have a patient who's now in the proned position, who I have expended even more of their energy and more of their oxygen, who now is going to continue to deteriorate because of that. And like I said, it's much easier to code a patient who is in the supine position than in the prone position. So typically, it can be a very, very stressful 15 minutes. Some of the literature says that, you can allow them to sit with an oxygen, as an overhead O2 saturation into the low 70s without, cause for major concern. Of course, this really depends on what the rest of their vital signs are doing and ventilator synchrony is doing. I've listed here a couple of recruitment maneuvers that you can do to kind of help re-recruit lungs after they've de-recruited. There are, of course, some risks to doing each of these, aside from overinflating, that can influence changes in your hemodynamics. And so definitely not something that I would do very lightly, but it is nice to have a plan and to know that it is relatively normal for the oxygenation to kind of fall a little bit after we supine somebody. And by a little bit, I mean, it may fall quite a bit. And reproning them, I'm not saying that's a bad idea. Reproning them may be a great idea, but it is helpful to at least give it enough time for that patient to really settle out. So we've talked a lot about proning. We've talked about why we prone. We talked about the evidence of proning. We've talked about, who's a candidate for proning. The next question is, how do we actually prone people? So, like I said in the beginning, this has been a predominantly nursing-driven practice historically. There are now on the market several companies that makes fancy beds that, you hit some buttons and it turns the patient over. I have used those beds. Now I am part of a team that practices manual proning, where we, the nursing staff is really responsible for getting the patient ready and turning the patient, and respiratory therapy is very heavily involved, an important part of the process. And the manual proning process that was developed at the institution I'm at was an extremely interdisciplinary process with occupational therapy, physical therapy, respiratory therapy, multiple teams of physicians, nursing leadership, and I think has been extremely successful because of the success that I've seen and the ease of manual proning over the bed. I'm much more of a proponent of manual proning than I am utilizing the bed, but that is completely a personal preference. The institution that I work at now, it is not uncommon for the particular department, the pulmonary ICU, to have 4, 5, 6 patients proned, which we would not be able to do on a bed. And that is something that happens because we have the staff to support manual proning measures, which I'm very, very fortunate for. All right. Hopefully this was a little bit helpful on sort of the whys behind proning and what to look for. The biggest takeaway that I can tell you is drainage is good. It's going to happen. And when you supine somebody after they've been prone, expect them to deteriorate, because it will happen. Give them time to settle out. Otherwise, you may end up in an even worse situation. And one last thing people frequently ask me about is coding patients who are prone. So if a patient goes into cardiac arrest while they are in the prone position, there are a couple options. The department I'm in has gotten so fluid with prone therapy that we are extremely efficient at turning them as quickly as we can. And if we suspect that someone is on the verge of coding, just go ahead and supine them. I believe at this point the AHA has endorsed compressions with prone therapy. Don't quote me on that, but sort of the standard is if I don't have enough people in the room to supine safely, is that you can do compressions on a patient who is in the prone position, keeping in mind that you're doing compressions against the spine, which is a very rigid structure. So I really don't have any evidence on how much cardiac output you're going to get doing compressions in the prone position, but it's most likely better than nothing, which is a cardiac output of 0. So if you have to do compressions in the prone position, that's not necessarily the best thing, but it certainly is probably better than nothing. And then getting that patient supined as quickly as you can so that they can be taken care of in a more effective manner. All right, if you guys have questions, please let me know. Like I said earlier, if you are interested in learning more about ARDS, keep an eye out for the next talk coming up on ARDS. Thank you all for listening, and I hope this is helpful.